All right, so we're going to be discussing intracranial pressure. It's in chapter 57 called Acute Intracranial Problems. Increased intracranial pressure has many reasons. Almost all our exemplars discuss about that. So it's the brain and the CSF and the tissue. So the brain, the cerebral spinal fluid, and the tissue all contribute. It's thinking of the Morone-Kelly rules and all that, which I can put on my list of things to look for, understand better. So, as you know, learning is never ending, and you always have to write down a list. All right, let's talk about the pathophysiology of intracranial pressures. So, cerebral blood flow. So the effects of the cerebral flow could be cardiac, respiratory arrest, effects of pathophysiology, diabetic, coma, infection, toxicities, encephalopathy, states of brain trauma, tumor, cerebral hemorrhage, stroke, systemic hemorrhage, autoregulation, changes in diameter, vasodilation, limited collateral, ensures consistent cerebral blood flow, only effective for 70 to 150 mmHg. So that's what I have about cerebral blood flow. So there's this whole formula that I want to honestly research more about. It's called the cerebral perfusion pressure. So the CPP, MAP minus ICP. Let me say it one more time. Now, I have to do some research on it, and I highly suggest you all do because it's very important, and I'm learning this as I go. But CPP equals MAP minus ICP. Let's also talk about our risk factors in addition to that. So our risk factors are increased risk of trauma, such as weakness, medication, lifestyle, or premature infants, fragile blood vessels. These are just a few reasons. There's a lot of reasons. The factors that influence, there's arterial, venous, intra-abdominal, intrathoracic, can increase pressure, your posture, the temperature, blood gases such as CO2. So there's a lot of reasons. There are different stages, such as, so like total compensation would be stage 1. Stage 2 would be like decreased compensation, increased risk for ICP. Stage 3 would be falling compensation, increased ICP, and that's when you see the Cushing triad with the bradycardia, the hypertension with the widening pulse, and the irregular respirations. And stage 4 is when you see herniation, which is the imminent death that you would see. So the brain perfusion, like the brain needs a lot of oxygen. We're talking about 50 milliliters per minute per 100 gram of brain tissue. So it's a lot. Supraanterial, infratorial, compression on the foramen magnum can cause respiratory compression. That's a big thing to remember. So if it's which I'm going to do more research on. It's in part of my notes. So supra and infratorial has different effects. Let's talk about our clinical manifestations. So our clinical manifestations are really all over the place because really we're talking about the brain and just really getting a solid comprehension of every single lobe and how it affects, just like you need to know for strokes, you need to know for ICP, you need to know for so many reasons. It's good to just get that solid anatomy base down when we talk about the frontal lobe, the parietal lobe, the temporal lobe, all the nerves, cranial nerves, like know them inside and out and understand the different functions because it's impossible to like think, you don't just memorize it for this, you know it for the whole base of understanding. So the ocular signs, which is ocular, there's optic nerve 2, or there's ocular motor nerve, or your trochlear nerve, your abductions. Okay, you get the point. So you may see diplopia, blurred vision, eyelid ptosis, inability to move upward, so it's affecting the muscle, sluggish or no response to light, and a unilateral pupil dilation. So these are some things you may see with the eyes. The motor, you want to look for that ipstotonic posturing, so the thoracic arching in the back. Contralateral, so one side is not so like, the right side will affect the left side, and the left side will affect the right side, so contralateral. You may see responses of the body if they're in a coma for noxious stimuli. So decerebrate is extension, whereas decorticate may be flexion. But these two signs, so decorticate, flexor, and decerebrate is extensor. But these are effects you may see. Nausea, not preceded by not preceded by projectile vomiting. There's a lot of things in here. So you may see a headache in these patients, often continuous, and it's worsening in the morning. All right, so worsening in the morning is different because you know how some of them say worse in the morning, and even time matters, often continuous. Changes in vital sign, temperature, Cushing triads. What is Cushing triad? It's our bradycardia, our hypertension, our irregular respirations, and with the widening pulse pressure, difference between the systolic and the systolic. Changes in LSE, you may see a flattening effect of coma in these patients. For cerebral edema, so cerebral edema may be cause of a mass lesion, head injuries, cerebral infection, a vascular insult, toxic or metabolic encephalopathic conditions. So you want to think of 3 different types. So there's a vasogenic, cytotoxic, and interstitial. Went through this fast. Okay, so the vasogenic is most common in the white matter, mainly leaks from intravascular to intravascular brain tumor, abscess, ingested toxins, increased in the permeability of the blood-brain barrier, increase of extracellular volume, so neurologic deficits, headaches, consciousness. This can all be the cause. So cerebral edema is one of the causes of ICP. So cytotoxic is a little bit of a different cause. Disruption in the cell membrane integrity, so it's destruction of lesions, trauma, brain tissue, hypoxia. SIDH, there may be a fluid shift from the extracellular to intra, swelling and loss of cellular function, blood-brain barrier still intact. Whereas the other one, the blood-brain barrier was disrupted in the vasogenic. And then there's interstitial, just like in the in middle, not inside the cells. So those are all the clinical signs and symptoms. Now, I just want to talk real quickly, like what as a nurse we need to assess, and then I could talk about quickly about the diagnostics. I need to figure out that one. Okay. So for nursing, you want to check for their motor. So like look at their motor strength, have them squeeze your hand, palmar drift test, raise the foot of the bed or bend the knees. Motor response, you want to see if there's spontaneous response to pain. Unconscious central sternal rub, mandibular pressure, squeezing trapezius muscle, supraorbital pressure, or peripheral nail bed. So this is just checking for the motor. There's respirations of coma. So let's look at that real quick. There's different kinds of respirations you may see. So the Cheyne's Stoke respirations are cycle of hyperventilation with apnea, whereas the central neurogenic hyperventilation sustained irregular rapid deep breathing, and then apneustic breathing is prolonged inspiratory, then a pause. And then there's cluster breathing. So there's 4 different types: Archaean, Stoke, central neurogenic hyperventilation, apneustic breathing, and cluster breathing. So reviewing those would be good. So Stoke is cycles of hyperventilation with apnea. Central neurogenic hyperventilation is sustained irregular breathing, deep breathing. Apneustic breathing, prolonged inspiratory with a pause, and cluster breathing, inspiratory with clusters of breathing and then a pause. All right. So then we can talk about the eyes. So you want to compare the eyes when you're doing your assessments. The pinpoint can be a pons damage or like drugs. A bilateral dilated fixed pupils is an ominous sign. Dilated pupil, compressed cranial nerve 3 can be a sign. Pupils react slowly or briskly. That's how you would evaluate. And pupils healthy would be considered equal bilateral reacting to light. All right, so some other things you're going to do is also, like if they're not conscious, an oculocephalic doll's eye. You want to see their eyes are moving to the side. Moving to the side would be oculocephalic. Oculovestibular is a caloric stimuli. Okay, so oculovestibular. I'm going to look this up again. I'm pretty sure like they put fluid in the ear and it's supposed to cause pain. Correct? Know your cranial nerves very well, inside and out. There's 12 cranial nerves. 3, 4, and 6 have to do with eye control, and corneal reflex is your 5 and 7. Okay, so you also want to assess for your LOCs, your glaucoma scale, and your vital signs. All right, so your diagnostics are going to be CT, MRI, PET. Remember, you're measuring for intracranial pressure. You also want to measure for the cerebral perfusion pressure, which is CPP equals MAP minus ICP. So I actually have a little note in here that may help us. Increased intracranial pressure alters the equation of CPP equals MAP minus ICP. Cerebral perfusion pressure decreases, leading the brain ischemia, increasing blood pressure. Cerebral blood vessels dilate. This can result in a cerebral hemorrhage. In addition, cerebral edema further contributes to increased cerebral pressure. So that doesn't really answer how the equation works 100%, but helps us understand how it works, but not necessarily like the actual math of the MAP part. All right, so also they may do a brain oxygenation devices such as an X-ray for placement. So they use a Licox, which is assessing in the white brain matter. What it's basically doing is it's assessing for oxygen in your brain. So you want to see it to be 20 to 40 mmHg. And there's also another one called a jugular venous bulb catheter, which is 55 to 75%. If it's below 50%, that's a problem. So jugular venous bulb and the Licox are the ones that measure for oxygen. It says no, I'm going to have to research this more, but it says no lumbar puncture. And I'm pretty sure because if you have increased intracranial pressure, you can't be having a puncture in the lumbar area. Really important to remember that. All right, so you also cerebral angiography, a Doppler and evoked potential response. So ICP, remember these values, they're really important to know. ICP needs to be 5 to 15 for the pressure, and healthy, sustained at 20. Yeah, shouldn't be more than that, should be within that range. So indications, you want to make sure that CT, MRI to indicate for measuring this. A glaucoma scale, 8 or less, you would probably use it. So that's where you do the eye opening, the best motor response, verbal. You measure the mean pressure and waveform, so normal, elevated, plateau. You also want to assess for infection. You don't want this to be infected. If you're going to get an accurate reading for the drainage of this, that you get fluid from this, you want to close it for 6 months to get an accurate reading if you do that. So 6 minutes. This is a gold standard ventriculostomy with the ventriculostomy is the gold standard of measuring ICP. And it's used with an external transducer. So also with this ventriculostomy, you're going to be using leveling with the transducer with a foramen of Monroe. So you want to level with the transducer with the foramen of the row, which like the ear. It's called tragus of ear. Write this down because I want to see it physically to help everyone out. So patient is repositioned and needs to be if patient is repositioned, you need to remember that they need to be re-zeroed for this. So leveling with the transducer is really important when it comes to ventriculostomy and the ICP stuff. With the foramen of Monroe, also known as the tragus of ear. So incorrect readings, it could be that there's a CSF leak, there's obstructions in the catheter, there's kinks, bubbles in the air tubing, differences in height and transducer and the bolt, incorrect height for drainage system. So remember that if you need to assess that before you call a healthcare provider. So some complications that really stood out to me was inadequate cerebral perfusion and cerebral herniation. Now we got to figure out what are we going to do as a nurse to treat these patients. So nursing really focuses on, looking at a lot of assessing and ongoing monitoring. You want to look at the pupils, the LOC, the vital signs, the frequent assessments every 15 minutes to 2 hours within a bracket, depending on the protocol of the hospital. Positioning is important. So you want to avoid neck compression and prevent extreme flexion. Do not put like 2 pillows underneath the patient. Turning slowly. Elevating the bed to 30 degrees, not more. Avoid coughing, straining, Valsalva maneuver. Hip flexion increases ICP as well. Suctioning don't suction so much, because that increases ICP, because of coughing. Eliminate noise and prevent constipation, because you don't want to increase that ICP. Safety is also really important. So because there are risks for seizures, seizure precautions like light sedation, maybe chemical, monitor LOC, their level of consciousness, quiet, non-stimulating environment when it comes to seizures. Psychologic, you want to assess for the family resources, and interdisciplinary social work. So fluid electrolytes, that's the next one, because with ICP, it could be for multiple reasons. So it really depends on the reason. So IV, daily electrolytes, monitoring DI or SIADH, because that could be the reason for ICP. Monitoring INO, you want to make sure, so normal urinary output is 30 milliliters per hour. Really got that down now. 200 to 300 an hour, you want to notify the physician, because that could be a sign of DI, you don't know. Avoid overhydration, because more hydration may need the NG, and because more hydration can increase ICP, and you may need an NG or gastrostomy. So let's talk real quickly about respiratory now. So respiratory, the airway, remember you want to keep it open, 30 degrees head of bed, suction, not more. The abdomen, you want to minimize distension, monitoring the ABGs, maintain ventilator support. It's pretty straightforward at this point. You want to treat the underlying cause. Is it a hemorrhage? Is it for hydrocephalus? Was it tumor or edema? So it really just depends. So you want to keep their adequate oxygenation. Like PaO2 partial, you want it to be 100 or more. And PCO2, you want to keep it to 35 to like 45. If it's not, they may need mechanical ventilation. They may need endotracheal tube or tracheostomy. So just be aware of that. Surgery, they may need tumor removal or hematoma evacuation, craniectomy. So these are surgeries that are available that you may need to be preparing these patients for. Okay, we'll talk about pharmacology last. So nutrition, hypermetabolic or hypercatabolic during this time of ICP, they may be. So malnutrition promotes cerebral edema. Just be aware of that. So you want to monitor the INO and electrolytes. You want to monitor insensible loss. You want to monitor serum osmolality. So really strict INOs as well. Enteral parental nutrition may be needed. They may need IVs, but remember, it's like probably normal volemic. And early feedings within 3 days of the injury. All right, let's talk about real quickly about the pharmacology behind all this. All right, because really this is like the base of all the exemplars we're going to have. So you got to know this stuff. Diuretics, they mean an IV or diuretics or IV isotonic. Diuretics help get rid of the fluid. Antipyretics to lower the risk for seizures and just to help lower the temperature in general. Anti-seizures, anticonvulsants, TPN if enteral feeding is not possible. Vasoactive medications. A GI prophylaxis like propantazole may be needed if they're feeling nauseous, or they may just need to get rid of that, I guess. Sedative chemical restraints, paralysis, analgesics, barbiturates. It really depends on the patient. The three that I want you to remember is hypertonic saline brings fluid out of the cell. So if you give hypertonic solutions on the outside, it will bring the fluid outside of the cell. So that's cool to remember that. Mannitol is plasma expansion, osmotic effects. So monitoring INO with that is important because that will help get rid of the fluid. And corticosteroids will reduce the swelling. So really I talked about everything. Just remember to kind of look into that formula CPP equals MAP minus ICP. And it says really big boldly no lumbar puncture. So I wanted to look into that too and find out the reasonings why that is. So that is everything for increased intracranial pressure, and happy studying and good luck.